Now we are going to discuss penis and urethra. Penis and urethra. Okay, so in penis and urethra, first of all we are going to discuss the anatomy. So see the anatomy of urethra. First, what is the length of male urethra? The length of male urethra is 20 centimeter, and what is the length of female urethra? 4 centimeter. Okay, so what's the length of male urethra? It is 20 centimeter, and what's the length of female urethra? It is 4 centimeter. So females have shorter urethra, and that's why they have increased risk of UTI. After that, urethra is divided into anterior urethra and posterior urethra. What are the parts of anterior urethra? It's penile and bulbar. And what are the parts of posterior urethra? It's membranous and prostatic urethra. So see the parts. So here you can see this is posterior urethra, and the parts are prostatic and membranous, and this is anterior urethra, and the parts are bulbar and penile urethra, right? Lots of questions are asked related to this anatomy. First, which one is widest and most dilatable part of urethra? And that is prostatic. So prostatic is widest, it is widest and most dilatable. Most dilatable. Okay. Next is which urethra is shortest, narrowest and least dilatable? And membranous urethra is shortest, narrowest and least dilatable. So membranous urethra, this is shortest, narrowest and least dilatable. This is least dilatable. Okay, in this diagram you can see which urethra is longest. So you can see that penile urethra is longest. So penile urethra, this is longest. Okay, imagine there is a question, and the question is asked that what is the narrowest part of urethra? So which is the narrowest part of urethra? And in option, suppose membranous urethra is given as well as meatus. So if meatus as well as membranous urethra both are given in the option, so which one you are supposed to choose is the meatus. So narrowest part of urethra is meatus. If meatus is not given in the option, then only we have to choose what? Membranous. Okay, so this is important point. This is meatus, and meatus is narrowest part. If meatus is not given in the option, then only you will choose which one? Membranous. So this is the basic anatomy. Now see the anatomy of penis. Easy to understand. This is glans penis. Now here you can see that this is the foreskin or prepuce. Okay. So what are the parts? This is glans penis. This is foreskin or prepuce. Right. And this is coronal sulcus. Sulcus or coronal sulcus. Okay, some students are confused that which part of penis is dorsal and which part of penis is ventral. Okay, so this lower part, this is known as ventral part, and this one is known as dorsal part. Clear? So what is the application of this thing in surgery? See, generally, meatus is going to open at the tip of glans penis. Meatus opens at the tip of glans penis, right? Imagine that this meatus is going to open where? The ventral aspect or lower aspect. So if the meatus is going to open over the ventral aspect of penis, and this is known as what? Hypospadias. Hypospadias. And just opposite of this, if the meatus is going to open over the dorsal aspect of the penis, so if meatus opens over the dorsal aspect, this is known as epispadias. Epispadias. Clear? So one by one we are going to discuss. First we are going to discuss the hypospadias. So what's the problem in hypospadias? See, this is the penis and this is the meatus, and meatus is going to open over which aspect of penis? Over the ventral aspect of penis. Okay, so this is hypospadias. Hypospadias is very common. It's the most common congenital anomaly of urethra. It's the most common congenital anomaly. of urethra. Okay, what is the incidence of hypospadias? The incidence of hypospadias is 1 in 250. We discussed the incidence of horseshoe kidney. What is the incidence? 1 in 400. And what is the incidence of unilateral renal agenesis? 1 in 1000. So these three incidences are frequently asked in urology. First, incidence of hypospadias. Incidence of hypospadias. This is 1 in 250. See how common it is. Horseshoe kidney and unilateral renal agenesis. In horseshoe kidney it is 1 in 400. 1 in 400, and in unilateral renal agenesis it is 1 in 1000. Okay, before discussing hypospadias you should know the development of urethra. So how urethra is going to develop? Now imagine this is penis. Okay, this is the ventral aspect of penis and this is the presence of urethral fold. Okay, so urethral fold is present over the ventral aspect. Now what happens? The urethral fold is like this, and how it is going to close? From posterior to anterior direction. So when urethral fold is going to close from posterior to anterior direction, what happens in certain patients? Yes, there is no closure of this anterior part. So a question is asked that in hypospadias which types are more common, the posterior types or anterior types? So obviously it is anterior types which are more common. So see, what are the types of hypospadias? If the meatus is going to open, normally where is the meatus? At the tip of glans penis. This is normal. If the meatus is going to open not at the tip, at some other area of glans, so this is known as glanular. If it is going to open in coronal sulcus, this is known as subcoronal or coronal. In the distal part of penis, distal penile. In the mid shaft, it's mid shaft. In the proximal part of penis, it's proximal penile. And if it's located at the junction of penis and scrotum, this is penoscrotal. And if it's located in the scrotum, this is scrotal. And if it's located in perineum, this is perineal. So these are the types of hypospadias. Clear? We discussed that anterior types are more common. And see, this distal penile, coronal and glanular, these are anterior types and these are responsible for 70% of the cases. Now just use your common sense and tell me which one is the most common type overall. So overall most common type is most distal one. Clear? So which one is the glanular? Because it is last to close. Okay, so if you see this anterior types, these anterior types are responsible for 70% of the cases, and out of these overall which one is most common? It's the glanular. Right? So in hypospadias, only meatus is not abnormal. There are lots of other abnormalities. Now see the development. Imagine that this is the penis, this is the glans penis, and here the urethra is going to open. So what is the problem? You can notice that this part of urethra is not going to develop. And if this part of urethra will not develop, what will happen? In this part there will be fibrosis, and because of this fibrosis, what is the problem? The length of penis will be shorter. That's known as microphallus. And this fibrous area, if you are going to feel, this is felt like a chordae. And over which aspect this chordae is present? Obviously over the ventral aspect. See, around the glans penis there is preputial skin. So there is prepuce. What is the problem? This preputial skin is also not going to close. Where? Ventrally. So the prepuce is present over the dorsal aspect, and this is hooded prepuce. So what happens? It is not present ventrally, not going to fuse ventrally. So there is hooded prepuce. Third thing, see, this is the urethra, white colored, and this is the glans penis. Okay, but what is the problem? If there is hypospadias, this glans penis is also not going to fuse. Over which aspect? The ventral aspect. So what kind of glans penis will be there? There will be flattened glans penis. There will be meatal stenosis. So all these are abnormalities or associations with hypospadias. So see, this is a case of hypospadias. Here you can notice that this is the opening. So what is the problem? You notice that here there is meatal stenosis. There is meatal stenosis. There is abnormal opening of meatus. So what? There is ectopic meatus. Right? What you can see, this, it is like a hood. So this is hooded prepuce present over which aspect? Dorsal aspect. So what? There is hooded prepuce. And this is present over which aspect? Dorsal aspect. There is presence of ventral chordae. Ventral chordae. Right? You can see the shape of glans penis, it is flattened. So here, this is flattened glans penis. There is short length of penis, so that is microphallus. So this is what? Microphallus. Okay, these are the associations. Now see, in hypospadias we have to reconstruct the urethra, and for the reconstruction of urethra, what? This prepuce is used. And since this preputial skin is used for reconstruction of urethra, what is contraindicated in hypospadias? Circumcision. So important point, that in hypospadias, circumcision, it's contraindicated. Why? Because the preputial skin is used for reconstruction of urethra. Now see, what are the problems in the patients of hypospadias? This is the patient, and imagine that the patient is having this glandular type of hypospadias. In this patient, significant problems are not there. But what is the problem? You can see this is the normal urine stream. But in this patient, what is the stream of urine? It will be going down like this. So what is the first problem? There is abnormal stream of urine. Okay. Imagine if a person is having proximal type of hypospadias and the patient is an adult patient. So in adults, if there is proximal type of hypospadias, right, what is the problem? First, there will be pain on erection. Why? Because there is chordae. So there is painful erection. And suppose this patient is going to penetrate the vagina. What happens at the time of ejaculation? Most of the semen, can you see? Most of the semen will be deposited outside the vagina. So in posterior types, what is the big problem? There is a problem of infertility. So these are the problems in patients of hypospadias. So see the clinical features. These patients have abnormal stream. Abnormal stream. There is painful erection. Painful erection. And especially in posterior types, the patients have infertility. Why? Most of the semen is deposited outside the vagina. So what is the problem in this patient and what is the correction? See, the best first question, what is the best age for correction? So best age for correction or repair is 6 to 12 months. So whenever we are planning the repair, what's the best age? Best age, it is 6 to 12 months. There is another question which is asked, what is the best age for orchidopexy? The best age for orchidopexy is 6 months, and orchidopexy should not be delayed beyond 12 months. But best age for hypospadias repair is 6 to 12 months. Now see what is the principle of repair. In this case, see the problem. Here is the meatus. So what I have to do? I have to advance the meatus till glans penis. So this is known as meatal advancement. And after doing meatal advancement, you have to reconstruct the glans penis also. So this is known as what? Granuloplasty. And generally both of these are performed together. So this is known as integrated. So meatal advancement, granuloplasty integrated, and in short it is known as magpie, right? So what's the treatment? Generally we perform magpie, meatal advancement, granuloplasty integrated. There are various named repairs and the names of these repairs are frequently asked in exams. So what are those named repairs? The named repairs for hypospadias. So the named repairs are first Dennis Brown. This was asked many times. Dennis Brown, Thiersch Duplé, So Thiersch, Duplé, Brekas, Matthews, and Asopa and Duckett. Okay. Asopa is an Indian surgeon and he is from Agra, right? So these are the named repairs. Now generally the repair of hypospadias is performed in pediatric surgery as well as in plastic surgery, and it is said that experienced surgeons should perform the surgery. Why? Because the chances of success are maximum with first surgery. That's why it is recommended that the surgery should be performed by experienced surgeons. Okay, now see what is the complication. Imagine that I'm going to perform meatal advancement granuloplasty integrated. So initially this was the urethral opening, and what I did, I advanced this opening till the meatus like this. Whenever I reconstruct the urethra, inside that reconstructed urethra, I insert what? I insert the infant feeding tube. So infant feeding tube is inserted. Over that graft is going to heal, or reconstructed part is going to heal. Okay, whenever we are going to remove the infant feeding tube, what if it's not done properly? If the surgery is not done properly, patients are going to develop what? Urethral fistula. So what will happen? There will be one opening here, and there are one or two opening here. So many openings are there. When patient is going to pass urine, what will happen? This is the problem. Clear? So urethral fistula is most common complication. And how much is the incidence? 10%. Clear? So what is the most common complication? It's the urethral fistula. And how much is the incidence? It's the 10%. This is the most common complication. That's why it is said that it should be performed by experienced surgeons. Why? Because the chances of success are maximum with the first surgery, and if you are going to do second or third surgery, anatomical landmarks are lost and the success is very less. Clear? So it should be performed by experienced surgeon. Just opposite of hypospadias. In hypospadias, the opening is over the ventral aspect. In epispadias, it is over the dorsal aspect. So have a look. Epispadias. In comparison to hypospadias, epispadias is very less common. So it is uncommon. Now see the problem here. This is the glans penis, and in this is the problem. So what? There is opening of meatus over the dorsal aspect. See, this part of urethra is not going to develop, and if this part of urethra is not going to develop, so what is the problem? Yes, there is presence of chordae, and now chordae is present over which aspect? Dorsal aspect. So in these patients, what? There is meatus which is opening over which aspect? Dorsal aspect, and there is presence of chordae. Chordae is also present over which aspect? Dorsal aspect. In females also there is epispadias. What's the problem? In females there is fissure or cleft in anterior part of urethra. So what's the problem? There is fissure or cleft in the anterior part of urethra which opens just above the clitoris. Clear? So in females there is fissure or cleft in anterior part of urethra, and this is going to open where? Just above clitoris. Just above clitoris. See, when we were discussing the bladder and we were discussing ectopia vesicae or extrophy bladder, we discussed that ectopia vesicae is associated with epispadias. So what is the problem? This epispadias is associated with ectopia vesicae. Now what is the problem in females and what is the problem in males? If we see in females there is bifid clitoris and widely separated labia, and in males there is undescended testis and shallow scrotum. There is one more problem in females, that there is maldevelopment of sphincters. So with this abnormality of urethra, if there is maldevelopment of sphincters, what is the problem? In females there is incontinence. Okay, so see the associations in females and in males. Okay, in both there is ectopia vesicae, ectopia vesicae. In both here there is bifid clitoris and widely separated labia. There is widely separated labia. Clear? In males there is undescended testes and shallow scrotum. Clear? And in females there is maldevelopment of sphincter. And because of this maldevelopment of sphincter, what's the problem? These patients have incontinence. And it is seen that this maldevelopment of sphincter, it is more common in posterior types. Clear? So whenever a patient is having epispadias, we have to correct three problems. First, foremost, what you have to correct the incontinence. Second, since there is presence of chordae, you have to excise the chordae. And third, you have to advance the meatus till glans penis, right? So what is done in the management? In the management of epispadias, first we have to correct the incontinence. So correction of incontinence. Second, excision of chordae. And advancement of meatus. Advancement of meatus till glans penis. Third congenital abnormality is posterior urethral valve. So it's the posterior urethral valve. So the term is self-explanatory. Where is the valve? In which part of urethra? It's present in the posterior urethra. Okay, especially which part? Is the prostatic part, right? So what happens? These patients are having folds of urothelium in the posterior part of urethra, right? And what is the problem? Can you see this is unidirectional valve? So when the patient is trying to pass urine, the valve is closed. But if you're trying to insert some catheter, you are going to easily insert the catheter. Now see exactly what's the problem here. This is the bladder. This is the prostate. This is the prostatic urethra. Here is the verumontanum, and this is the external urinary sphincter. So what happens? There is presence of urothelium which starts from prostatic urethra, and what is the extent? The extent is from prostatic urethra till external urinary sphincter. Okay, so first question, this is prostatic urethra. So it is characterized by presence of valve, and what's that? That's the folds of urothelium. Folds of urothelium. What is the extent? Extent is from prostatic urethra till external urinary sphincter, and posterior urethral valve is exclusively an abnormality of male urethra. Exclusively an abnormality of male urethra. I told you that in surgery in various classifications, if the classification starts from 1, 2, 3, 4, 5, so generally what is the most common type? 1. And if classification starts from A, B, C, D, E, so generally most common type is A. There are exceptions, but usually this is followed. So in posterior urethral valve, what is the most common type? It's the type 1. Which one is most common type? It's the type 1. And what is the location of this type 1? Just distal or at verumontanum. So the location is, it's just distal or at verumontanum. Now see, once this question was asked, and in the question both options were there, that what is the most common site of posterior urethral valve, one option was just distal to verumontanum and the second was at verumontanum. So which one you will choose? If both of these are mentioned, you are going to choose just distal to verumontanum. Now see, what are the problems in posterior urethral valve? This is kidney, this is ureter, this is the bladder, This is prostate and this is urethra. This is ureter. When we were discussing kidney and ureter, we discussed that because of this posterior urethral valve, there is obstruction, and because of this obstruction, there are back pressure changes. So, what is the first problem? These patients have vesicouretic reflux. So, these patients have vesicouretic reflux in more than 50% cases. First, since there is distal obstruction, so the patients will be having hydronephrosis. So there will be only hydronephrosis or hydrouretronephrosis. So you will notice that there is hydrouretronephrosis. And this is unilateral or bilateral. So actually speaking, this is bilateral. So patient is having bilateral hydrouretronephrosis. Obstruction is distal to bladder. So in majority of patients, the bladder will be distended or collapsed. Obviously distended. During pregnancy, means during intrauterine period, since this obstruction is there, so because of that, what will happen? There will be stretching of the tissues proximal to obstruction, and because of this stretching, there is collection or extravasation of urine in the fetal peritoneal cavity. So after birth, you will notice that the fetus is having ascites, and that ascites is nothing. There is collection of urine in the peritoneal cavity, and which is known as what? Urinary ascites. When the child is born and you are going to palpate the abdomen, bilateral kidneys are enlarged because there is hydronephrosis. So what's the problem? Patients will be having, yes, bilateral palpable intra-abdominal mass. And since both kidneys are involved, after birth, the patient will be symptomatic or asymptomatic. So patient will be symptomatic. These are the problems. Now see, what are the associations? Apart from vesicouretic reflux, these patients have what? These patients have oligohydramnios. There is pulmonary hypoplasia. Pulmonary hypoplasia, renal parenchymal dysplasia, renal parenchymal dysplasia, and bladder dysfunction. There is bladder dysfunction. Okay, these are the associations apart from VUR. Now, out of these four options, one question is asked that which one is the most common cause of death? Most common cause of death in posterior urethral valve. And what's the correct answer? It's the pulmonary hypoplasia. This is the most common cause of death. When we were discussing congenital diaphragmatic hernia in esophagus, we discussed that in congenital diaphragmatic hernia also, most common cause of death is pulmonary hypoplasia. So the poor prognostic factor was what? Pulmonary hypoplasia. So here also it's the pulmonary hypoplasia which is the most common cause of death in posterior urethral valve and congenital diaphragmatic hernia. Clear? 1 point. Second, so what are the clinical features? First, patients will be symptomatic after birth or asymptomatic. So most patients are symptomatic. Okay, what you're going to feel if you're going to palpate abdomen? There is bilateral palpable abdominal mass. What else on palpation? Distended bladder. There is distended bladder. Okay, what else? There is ascites, and actually speaking, the content of this ascites is urine. So this is known as urinary ascites. So what's this? This is urinary ascites. Clear? These patients have vesicouretic reflux. So these patients have increased risk of UTI or infections. And what is this bilateral palpable intra-abdominal mass? This is because of bilateral hydrouretronephrosis, and you can easily detect this on ultrasound. So if we are sending the patient for ultrasound, we can find that there is bilateral hydrouretronephrosis, there is distended bladder, there is presence of ascites. By the way, obstruction is in the posterior part of urethra, and generally for posterior urethra, what is the investigation of choice? It is MCU. So micturating cystourethrogram is the investigation of choice. And this MCU is investigation of choice for three conditions. One, posterior urethral valve. Second, posterior urethral stricture. And third, VUR. So how we are going to make the diagnosis? Investigation of choice for diagnosis is MCU, micturating cystourethrogram, and MCU is investigation of choice in these conditions: posterior urethral valve, posterior urethral stricture, and what else? Vesico-uretic reflux. Another question, this was asked as an image-based question, that after 28 weeks, if ultrasound is done, means during pregnancy, after 28 weeks, if ultrasound is done, what's the name of that sign which is seen? So this is the sign. What is this sign? You can see here that here is the obstruction in the posterior urethra, and this is the distended bladder, and it is looking like keyhole. You have seen a lock, and in that lock we have to insert the key in the hole, so that is keyhole. So this is what? Keyhole sign. This was asked as an image based question, generally seen in posterior urethral valve on ultrasound after 28 weeks. What is the good thing about this posterior urethral valve? That this is unidirectional. So see the simplified diagram. If there is unidirectional obstruction, what? If you want to insert some catheter, clear? You can easily insert because there is unidirectional obstruction. In fetus or newborns, we are going to insert what? Infant feeding tube. So when we insert infant feeding tube, what happens? The obstruction is relieved and creatinine comes down. So whenever creatinine becomes normal, we are going for endoscopic fulguration of the valve. So via urethra, can you see? I'm going to fulgurate these folds of urothelium. Endoscopic fulguration. Imagine that even after insertion of infant feeding tube, creatinine is still raised. It means obstruction is not relieved completely. In those cases, we have to perform suprapubic cystostomy by Blockson technique. And after that, creatinine comes down and we perform the endoscopic fulguration. Okay, so how we manage these patients? First, insert infant feeding tube. There are two possibilities. First, creatinine becomes normal. In that case, we perform endoscopic fulguration. Second situation, creatinine is still raised. So it is still raised. In that case, we have to perform suprapubic cystostomy. The name of technique is asked sometimes. And what's the name of this technique? This is known as Blockson technique. And after that, creatinine comes down, means becomes normal, and we perform what? Endoscopic fulguration. So this is how we manage posterior urethral valve. Now tell me, what is the name of this condition? Here you can see that this is the foreskin of prepuce, and this foreskin or prepuce is contracted, and that's why it cannot be retracted over the glans penis. When foreskin or prepuce cannot be retracted over glans penis, this condition is known as what? Phimosis. So what is this? This is phimosis. Here, contracted foreskin or prepuce cannot be retracted over glans penis. What is the problem? What is the most common cause? It has been observed that most of the people, they are not going to clean this area. Yes, this is glans penis, this is prepuce. So there is collection of secretions here. Here, there is collection of secretions. So most of the people who are not going to clean this area, what happens? There is chronic infection. And because of poor hygiene, there is chronic infection. And because of this chronic infection, there is what? Phimosis. So what is the most common cause? The most common cause is chronic infection because of poor hygiene. Simple. See, phimosis can be congenital or it can be acquired, right? So it can be congenital, that's why it is seen in newborns, young children, and acquired. So what are the acquired causes of phimosis? It can be because of trauma, it can be because of carcinoma penis and BXO. So acquired causes: trauma, carcinoma penis, and balanitis xerotica obliterans. See, phimosis increases the risk of carcinoma penis, and carcinoma penis can lead to phimosis. Both are related or associated. Now see what is the presentation. There are two presentations. First, sometimes the parents are bringing the child and mother is going to tell what is the problem of the child. See, this is the child and mother is going to tell you that, sir, whenever the child is going to pass urine, initially what happens, there is ballooning of prepuce. Why there is ballooning? Because the urine is going to collect under the prepuce, and after that what, it comes out. So the child is having ballooning of prepuce. Okay, this is one problem. Sometimes difficulty in passing urine or micturition. Now see the problem in adults. These patients are coming to us, especially these are college going students, and they come to us and they say that, sir, I am having difficulty in intercourse. Why? Because since the prepuce cannot be retracted back over the glans penis, there is difficulty in penetrating the vagina. So what are the complaints? There is difficulty in micturition or passing urine. In young children, there is ballooning of prepuce. Clear? And in adults, there is difficulty in intercourse. Difficulty in intercourse. Now see the complications. If this prepuce cannot be retracted back, obviously the patient is not able to clean this area, and if patient is not able to clean this area, there is infection of glans and prepuce, that is known as what? Balanoposthitis. Balanoposthitis. Second, the secretions, sometimes these secretions are going to solidify, and if the secretions are going to solidify, it is converted into a stone just below prepuce. So this is known as preputial stone or preputial calculi. And third problem, what happens? The chronic inflammation is going on, and chronic inflammation is going on, that's why this condition is going to increase the risk of squamous cell carcinoma, means carcinoma penis. So these are the complications. So what are the complications? So there is balanoposthitis, there is preputial calculi or preputial stone, and third, there is increased risk of carcinoma penis. Now how we are going to manage? See, in children there is formation of adhesion between glans penis and prepuce. So what we advise the parents, that they should apply the steroidal cream for 4 to 6 weeks, and generally the condition is going to resolve. If despite of application of this cream for 4 to 6 weeks, if the condition still persists, or patients are having recurrent infections, or if patient age is 16 to 18 years, in those cases we can go for circumcision, right? So what are the treatment options? Management. First is conservative management. So what is done? Steroidal cream application for 4 to 6 weeks. Steroidal cream application for 4 to 6 weeks. And what is the second option? The second option is circumcision. This question was asked 2 to 3 times in all India, that what are the indications of circumcision? So first, no improvement after steroidal cream application. So there is no improvement after steroidal cream application. Second, if there is recurrent infections, history of recurrent infections, and if the age of patient is 16 to 18 years. Clear? So in these cases we should go for circumcision. Now tell me, what is the name of this condition? What you can see in this condition, you can see that here the retracted prepuce is going to form a ring around glans penis. So what happens? There is formation of a ring around glans penis, right? So what is the name of this condition? This condition is known as paraphimosis. So this is what? Paraphimosis. We discussed that phimosis can be congenital or it can be acquired, but paraphimosis is only acquired. What happens here? The patient has to retract the prepuce, and then there is formation of a tight ring and paraphimosis is going to develop. Generally, you have seen that whenever we ask interns to insert Foleys, they are going to clean the area by no touch technique, and after inserting Foleys they forget to bring the prepuce back to its normal position, and then patient is going to develop what? This paraphimosis. So first, very important point, that it's only acquired. Okay, prepuce once retracted cannot be brought back to its normal position. What is the problem here? So there is formation of a tight ring around glans. So whenever there is formation of tight ring around glans, initially what happens? The lymphatic drainage is impaired, and because of this impaired lymphatic drainage, what's the problem? There is edema. Clear? So ring becomes further tight. So when it tightens the ring further, what happens? There is impaired venous drainage, so there is further edema. And when ring is very tight, arterial supply is also impaired, and what it can lead to? It can lead to gangrene. When the arterial supply is also impaired, it can lead to gangrene. But see, ring is not so tight that it can obstruct the urine flow. So urine flow is not obstructed. Clear? So what's the problem here? In severe cases, there might be gangrene of glans, but what? The urine flow, it's not obstructed. Now how we are going to manage? Suppose these patients are coming to our emergency, so we ask the patient to apply ice bag. How it works? Ice bag application, it is going to cause vasoconstriction, and when there is vasoconstriction, the edema settles and you can bring back the prepuce to its normal position. Suppose still patient is not improving, we go for manual compression and sometimes hyaluronidase injection. And in severe cases, we have one option of performing what? Circumcision. So what are the treatment options? Ice bag application, ice bag application, manual compression, manual compression. What else? Hyaluronidase injection. And in severe cases, we can perform what? Circumcision. Before discussing the priapism, let's first discuss the cut section of penis. So this is the cut section of penis, and in this you can see there is carpora cavernosum. This is carpora cavernosum, and there is carpora spongiosum. Okay, what are the components? You know that in carpora cavernosum there are presence of vessels. So this is artery and this is a vein. Okay, and what is there in carpora spongiosum? In spongiosum there is urethra. Okay, how to remember? Sponge absorbs water, so spongiosum is having water containing structure, and that is urethra. Okay, around this carpora cavernosum, what? There is tunica albuginea. So this is a layer, that is tunica albuginea. This layer is Buck's fascia. Outside of Buck's fascia there is Cooley's fascia. So this is what? Cooley's fascia. And outside this Cooley's fascia there is penile skin. These are the important structures. One by one we are going to discuss. So here what you saw that this is corpora cavernosum. This is corpora spongiosum, and in spongiosum there is urethra, right? Now around this corpora cavernosum you can see that this is what tunica albuginea. Okay, this layer you can see this is what bugs fascia. This is bugs fascia. Okay, and this one is Cooley's fascia, right? And this is penile skin. How to remember? Can you see from inside out? It's very easy to remember. From inside out it is A, B, C. So there is tunica albuginea, there is bugs fascia, there is Cooley's fascia. Okay, now what is the importance? See, if we are talking about priapism, which is persistent painful erection in absence of sexual stimulus or which persists beyond the sexual stimulus, in that what's the problem? Either there is increased flow of blood in corpora cavernosum, or there is impaired drainage of blood from corpora cavernosum. Okay, we will discuss. Second application of this anatomy is, suppose a patient is having Peyronie's disease. What is Peyronie's disease? In Peyronie's disease there is chronic vasculitis involving which layer? Corpora cavernosum. So there is formation of a fibrous plaque, and what is the location of that fibrous plaque? You can see there is presence of that fibrous plaque around dorsolateral aspect of penis. And which layer is involved? There is involvement of tunica albuginea. Clear? Third important point, in carcinoma penis, see, if the patient is having carcinoma penis, in carcinoma penis there is hematogenous spread, but it has been seen that the patients who are having even advanced malignancy, advanced carcinoma penis, the incidence of pulmonary metastasis is rare. Why? Because in hematogenous spread there should be involvement of vessels, and after involvement of vessels those tumor emboli are going to reach to the lungs. Now see, what's the problem here? Between the malignancy and the vessels of corpora cavernosum, what? There are two strong barriers. And what are these two strong barriers? One is tunica albuginea and second is bugs fascia. That's why even in advanced cases of carcinoma penis, these two strong barriers prevent the involvement of vessels, and that's why incidence of pulmonary metastasis is rare. Clear? So this anatomy is very, very important. One by one we are going to discuss. First we are going to discuss the priapism. So first, what is the definition of priapism? It is the persistent painful erection. So what kind of erection? It is persistent painful erection. Okay, in absence of sexual excitement or desire, or when it is going to persist after sexual excitement or desire. Okay, just understand the basic physiology of erection. So you see, this is the penis. Clear? In corpora cavernosum we discussed that there is artery and vein. So this is an artery and this is a vein. Clear? What happens during erection? There is increased blood flow to the penis, and relatively there is impaired venous drainage. So what happens? Yes, the penis is engorged with blood and this leads to erection. Now see the problem. What is priapism? Imagine that this patient is having AV fistula, arteriovenous fistula. So if there is formation of some AV shunt or arteriovenous fistula, what's the problem? Because of this fistula, yes, there is increased flow. So whenever there is formation of AV shunt or fistula, and because of this fistula there is increased flow to the penis, this leads to what? Erection, which is painful. This is high flow priapism. Second, imagine a patient is having some kind of tumor emboli, or there is fat emboli in the vessel. So in this vein some kind of tumor emboli is there, some fat emboli is there, or there is sickling of RBCs in sickle cell anemia, or if there is injection of vasoconstrictors, what happens? There is impaired drainage and that leads to persistent painful erection. This is low flow. So what happens in high flow? Actually the blood flow to the penis is increased, and in low flow there is impaired venous drainage. This high flow priapism is known as non-ischemic priapism, and the low flow priapism is known as ischemic priapism. Why? Because there is increased risk of ischemia. Why? Because there is collection of which kind of blood? Deoxygenated blood. If you are going to compare high flow from low flow, the question is asked that overall which one is more common? It is the low flow priapism which is more common. Now what is the problem in this case? In priapism, generally in majority of cases, what happens? There is collection of deoxygenated blood in the penis, and because of collection of deoxygenated blood in the penis, what happens? There is ischemia, and if there is ischemia, because of this ischemia there is cavernosal fibrosis and impotence. So what's the problem? It can lead to cavernosal fibrosis and impotence. Priapism is an emergency, right? And the treatment should be done within 6 hours. See, 2 questions are asked. You must be knowing testicular torsion. Testicular torsion is also an emergency, and the treatment should be done within 4 hours. In priapism, it should be done in 6 hours. So 2 questions. In testicular torsion, the treatment should be done within 4 hours, and in priapism, it should be done within 6 hours. Okay, so let's discuss in detail what are the causes. There are 2 types of priapism. First is high flow, and second is low flow. Okay, high flow, it is also known as non-ischemic priapism, and we discussed the low flow is known as ischemic. If we see both of these, which one is more common? Out of these 2, low flow priapism is more common, right? Now what is the problem in this high flow priapism? There is penile trauma, there is pelvic trauma, and because of this there is formation of AV shunt leading to increased flow. So what are the causes? Penile trauma or pelvic trauma, and because of these there is formation of arterial sinusoidal shunts. So there is formation of arterial sinusoidal shunts, and because of that there is increased blood flow to the penis. Okay, what happens in low flow priapism? There is occlusion of the veins, and overall most common cause in low flow priapism is what? Sickle cell anemia, which is responsible for priapism in children. So in children it is because of sickle cell anemia. Okay, anything which can cause obstruction. So in leukemia there is tumor emboli obstructing the venous drainage, fat emboli. In spinal cord lesions, and malignant penile inflammation. Malignant penile inflammation means suppose patient is having carcinoma penis, and in carcinoma penis there is hematogenous spread. So tumor emboli are going to enter into the veins, and these are going to cause what? Obstruction. So a question is asked, what is the first sign of metastasis in carcinoma penis? And that's priapism. Okay, so this is malignant penile inflammation, malignant penile inflammation. And what else? Sometimes vasoconstrictors are being injected, so trazodone injection. Trazodone injection. Okay, now see the presentation. Generally the child aged between 4 to 10 years suffering from sickle cell anemia and started crying in the midnight, and on evaluation the penis is erect. Okay, so see the clinical presentation. In children aged between 4 to 10 years, what happens generally, there is child is suffering from sickle cell anemia, and what happens, there is painful erection in the midnight. Okay, this is one presentation. What happens in adults, certain adults are having erectile dysfunction, and for performing Doppler sometimes we are going to inject the vasoconstrictors. Okay, so if you are going to inject vasoconstrictor substance, what happens, the erection is going to persist, and this leads to what, priapism. So in adults, what's the most common cause? It's iatrogenic. Clear? So how you are going to make the diagnosis of priapism? Just by looking at the penis you can make the diagnosis. Clear? So it's clinical, but sometimes you have to confirm your diagnosis, so then you need Doppler. Doppler is helpful in diagnosis. Diagnosis is made clinically. Okay, so how we are going to make the diagnosis? It's clinical diagnosis, right? Doppler is helpful in diagnosis, so we can go for Doppler. Okay, now if patient comes within 4 to 6 hours of priapism, what we have to give, we have to inject the ketamine. So we have to give ketamine injection, and in more than 50% patients, what, the symptoms improve, condition improves. So if patient comes within 4 to 6 hours, in these patients we have to go for ketamine injection. Clear? And more than 50% patients improve. Clear? Imagine if there is no improvement in these patients, what's the next step? Now see, this is the penis. The patient who is suffering from priapism, this is the penis, this is the glans penis. Here you can see that this is corpora spongiosum, and by sides there are 2 corpora cavernosum, right? What is the problem? In majority of cases it is low flow, so there is impaired venous drainage, so there is collection of what, deoxygenated blood. So what we are going to do, we have to insert the cannula in corpora cavernosum, and what we have to do, we have to perform aspiration. So saline irrigation, aspiration. So we have to remove the deoxygenated blood. So what we do first, insert a Foley's catheter, so that one person is holding Foley's catheter like this, and your assistant is injecting the saline and performing the aspiration. So aspiration, saline irrigation. So if there is no improvement, we go for aspiration and saline irrigation. Clear? And even after this there is no improvement, then we have to go for hyaluronidase injection. So hyaluronidase injection, right? Now see a second situation, patient who is having high flow priapism, and in that high flow priapism what we saw that there is formation of arterial sinusoidal shunts. So we have to perform the angiography. Which one? Internal pudendal artery angiography. So we perform selective internal pudendal angiography, and we are going to identify that what are the feeding vessels via which the blood is going into the penis, and we are going to embolize those arteries. Okay, so what is done in high flow priapism? In high flow priapism we go for selective internal pudendal angiography, and it's followed by embolization of feeding vessels. Embolization of feeding vessels. This is one treatment option. Second principle is, in the cavernosa, corpora cavernosum, there is increased blood flow in high flow priapism. So what is the second strategy? If we can shunt out the blood from corpora cavernosum, so we have to create certain shunts. especially in which type? High flow priapism, to shunt out the blood from corpora cavernosum. So what are the names of those shunt? This question is frequently asked in exam. So the surgical options, we have to create shunts to shunt out the blood from cavernosum. Clear? So what are the names? First, corporoglanular shunt. Corporoglanular shunt. And this was asked in all India. What's the name of this shunt? This is Winter's shunt. This was asked in all India. Okay. Then between corpora cavernosum and spongiosum we can create the shunt, and that's known as corporospongiosal shunt, and the name is Quakel or Sasher shunt. So the name is Quakel or Sasher shunt. Clear? Then we can create it in between corpora cavernosum and saphenous vein. So this is corporosaphenous shunt, and what's the name? It's known as Greyhack shunt. So the name is Greyhack, right? And the fourth is corporodorsal vein shunt. Dorsal vein. It is created between corpora spongiosum and dorsal vein of penis. And what's the name? The name of this shunt is Barry shunt. So this is Barry. Right? So these are the questions which are asked. These are one-liner questions of all India. So these are the named shunts performed for priapism. Now we are going to discuss urethral injuries. Okay. So before discussing urethral injuries, you should see the anatomy first, right? So we discussed already, this is bladder, this is prostate, and this is urethra. And the urethra is divided into posterior urethra and anterior urethra. So here, this is prostatic urethra, this is the membranous urethra, right? In posterior urethra, you can see this is prostatic, this is membranous, this is bulbar, and this is penile. Simple. So this is posterior urethra and this is anterior. Simple. Now there can be posterior urethral injuries, there can be anterior urethral injuries. Which one is more common? Posterior urethral injuries are more common. Okay. Now, generally, what is the site of injury in posterior urethral injuries? See, suppose this is the membranous urethra. Above membranous urethra, this is what? Prostatic, and below it is bulbar. So, if you see the junction, see, this is the junction of prostatic urethra and membranous urethra. So, this is prostato-membranous junction. And if you see this junction, this is bulbomembranous junction. So whenever tear occurs, generally it occurs at either prostatomembranous junction or it's going to occur at bulbomembranous junction. So the most commonly injured part of posterior urethra is membranous urethra, and in membranous urethra, what is the most common site? It is bulbomembranous junction followed by prostatomembranous junction. Simple. Second, you can see that this posterior urethra is located into which part of body? Pelvis. So if posterior urethra is located into the pelvis, what is the most common cause? Pelvic fracture. And what is the most common cause of pelvic fracture? Road traffic accident. And we discussed in bladder that road traffic accident leads to pelvic fracture. Pelvic fracture leads to extraperitoneal bladder rupture and posterior urethral injury, and that's why extraperitoneal bladder rupture and posterior urethral injuries are associated. Clear? So we are going to discuss in detail posterior urethral injury. Posterior urethral injury. Okay. First question, what is the most common site? It is the membranous urethra. Right? In membranous urethra, what is the most common site? is the bulbomembranous junction followed by prostatomembranous junction. Simple. What's the most common cause? Is the road traffic accident. This leads to pelvic fracture, and this leads to extraperitoneal bladder rupture and posterior urethral injury, and that's why these are associated. Now see the problem. Here you can see that there is injury of membranous urethra, and because of this injury what happens, you can see that there is collection of blood. So where is the collection? The collection of blood occurs in the pelvis, so this patient will be having pelvic hematoma. Clear? So what happens? There is urinary retention because of urethral injury, there is blood collection in pelvis, so pelvic hematoma, and at meatus you will notice that there is presence of blood. So what are the clinical features of posterior urethral injury? First, there is urinary retention, there is pelvic hematoma, and blood at meatus. Blood at meatus, okay? So generally these patients are road traffic accident patient having pelvic fracture. These patients are admitted in which department? Usually in orthopedics. And even after fluid challenge, what happens? There is no urine output, means urine is not coming, so there is urinary retention. Whenever we are going to palpate, the bladder is palpable, and if we are going to find the presence of blood at meatus, we suspect what? Urethral injury. And in these patients, what is the gold standard treatment? We have to insert suprapubic catheter, SPC, or suprapubic cystostomy. Now two questions are asked: whether in a case of suspected urethral injury you will insert Foley's catheter or not. So see, whenever there is a patient in whom we are going to suspect urethral injury, generally catheterization should not be done. Why? Because if you are going to attempt the catheterization, what's the problem? The partial tear can be converted into complete tear. So usually it's not done. But sometimes in viva, or sometimes the language of question is a bit difficult. Sometimes in viva, suppose the examiner is asking that imagine if a patient is having small partial tear, catheterization is contraindicated or not? So see, it's not contraindicated. A single gentle attempt of catheterization with smallest possible catheter can be done if partial tear is suspected. So if you suspect partial tear, single gentle attempt with smallest possible catheter can be done. But you have to see the language of question, and you have to see the options, and then you have to choose the correct answer. So usually catheterization is not done. Next, investigation is mandatory in suspected case of urethral injury. No, it's not mandatory. Generally we go for SPC. But if examiner insists that suppose I want to go for one investigation, or in question it is mentioned that which of the following investigation should be done or can be done in patients having urethral injury, so in that case we can go for what? RGU. So if a single investigation which should be done, in this case it should be RGU, retrograde urethrogram, and generally catheterization should not be done because you can convert partial tear into complete tear. Okay, how we are going to manage the gold standard treatment? It's the suprapubic cystostomy. Clear? Second, can we go for, because sometimes urologists are available even in emergency, so can we go for emergency repair? Emergency repair should not be done. Why? Because if you are going for emergency repair, there is inflammation. What is the problem? There is increased risk of impotence, incontinence, and stricture formation. So emergency repair should not be done. Why? Because Emergency repair increases the risk of impotence, incontinence, and stricture formation. Right? So you inserted SPC. So after how much time you are going to perform the repair? We have to perform the delayed repair. Generally it's done within 3 months. So after SPC, we perform delayed repair, right? And generally this delayed repair is performed within 3 months. Clear? So this is posterior urethral injury. Now see the anterior urethral injury. Which part of urethra is most commonly injured in anterior urethral injury? And that's bulbar urethra. So in anterior urethral injury, what is the most commonly injured part of urethra? It is bulbar urethra. It's bulbar urethra. Okay. So what is the mechanism of injury? Generally in these cases there is external blow, kick, or manhole injury, or false stride injury. So what are the mechanisms? Generally these patients have history of external blow or kick, or there is manhole injury. Okay. Now see, there are typical pictures which are given in some of the textbooks of this manhole injury. So here you can see a gentleman wearing suit hat is walking on the road. He is not very careful, and there is a manhole with tightly fitted lid. You have seen on the roads that there are manholes, sewer system, and there is tightly fitted lid. Sometimes it's loosely fitted, and sometimes in certain parts of India there is no lid at all. So you have to be very careful when you are walking on the road. So when there is a loosely fitted lid and this gentleman is putting the leg, what happens? Yes, the lid is in the air and this lid is going to crush the bulbar urethra. So bulbar urethra is going to be crushed between this lid and the pubic bone. How? See? So here you can see this is the pubic symphysis, so pubic bone, and this is a rod or sometimes the lid. So what happens? This bulbar urethra, it is generally crushed onto this pubic bone. So bulbar urethra is crushed onto the pubic bone, and after that what happens? Since the bulbar urethra is injured, you can see the blood starts collecting where it is going to involve the shaft of penis and bilateral scrotum. So how it looks like? This is the shaft of penis and this is the scrotum. So there is formation of hematoma involving shaft of penis and bilateral scrotum. So what is the shape of hematoma? This is butterfly shaped. So in these patients also what happens? There is blood at meatus, there is perineal hematoma, and there is what? Urinary retention. Okay. So clinical features, these patients have urinary retention, these patients have perineal hematoma. See, in posterior urethral injuries, we discussed that there was pelvic hematoma. Here, perineal hematoma, what kind of? Butterfly shaped, involving shaft of penis and bilateral scrotum, and blood at meatus. So there is blood at meatus. Simple. In this case also, what happens? How we are going to manage? We are going to put the SPC, suprapubic cystostomy, and we are going to manage this patient with delayed repair, and generally delayed repair is done within 3 months. What is the good thing? If we are going to compare membranous urethra is narrowest. So in comparison to membranous urethra, the diameter of bulbar urethra is a bit large. That's why there are certain patients who are going to develop stricture, but stricture is not that symptomatic. Okay. So here also how we are going to manage? SPC followed by delayed repair if patient is symptomatic, we have to give antibiotics also. Why? Because there is extravasation of urine, so to control infection antibiotics are also given. So here we give antibiotics to control infections. Why? Because these patients have urinary extravasation. Okay. And delayed repair means repair should be done within 3 months. Now see, when patient is coming again to us, since there is injury, at the site of injury there is fibrosis, there is healing. So after fibrosis there is formation of stricture. So majority of patients are going to develop stricture. So question is asked indirectly that what is the most common cause of urethral stricture? Yes, it's trauma. So urethral stricture, what's the most common cause of urethral stricture? It's the trauma. Okay. Whenever a patient is coming to us with urethral stricture, we have to investigate the patient, and you must be knowing that investigation of choice for diagnosis of posterior urethral stricture is MCU and anterior urethral stricture is RGU. So very important point. Investigation of choice for diagnosis of posterior urethral stricture and anterior urethral stricture. So in posterior urethral stricture it is micturating cystourethrogram MCU, and in anterior urethral stricture it is retrograde urethrogram, that is RGU. But see, whenever a patient is coming to us with urethral stricture, generally we don't ask that what was the problem, where is the stricture. We give them a form, and in the form it's written MCU plus RGU. What does it mean? If a question is asked indirectly that for best evaluation of urethral stricture, what is the investigation of choice? Doesn't matter whether this is posterior or anterior. If RGU is mentioned, MCU is mentioned in the option, MCU plus RGU is mentioned, what you are going to choose? MCU plus RGU. So this is best for evaluation of urethral stricture. Best for evaluation of urethral stricture. Okay. Now see why. First have a look of RGU and MCU, how it looks like. Nowadays image based questions are asked about RGU and MCU, that's why you have to see this picture. This is a picture of RGU. What happens in retrograde urethrogram? We are going to inject the dye from the tip of penis, and dye goes like this. So this is RGU, retrograde urethrogram, and here you can see this is bladder. Here you can see this is prostate, so this is prostatic urethra. This is membranous, this part is membranous, this is prostatic. You can see bulbar urethra, see the diameter, penile urethra, and this is the tip of penis. Okay, and in micturating cystourethrogram we are going to inject the dye where? In the bladder. That's why posterior urethra is better visualized. Okay, so you see this diagram. Now see this picture. This was RGU. Okay, and this is also RGU. Now if you compare here, you can see this is the bulbar urethra, and now can you see the bulbar urethra here? So what happens? You can see that there is stricture in the bulbar urethra. If you see this picture here, bladder is prominent, bladder. Here you can see this prostatic urethra, then there is membranous urethra, and here also you notice that what? There is stricture in the bulbar urethra. So this is RGU showing stricture in bulbar urethra, and this is MCU showing stricture in bulbar urethra. This is a question of NEET PG asked recently. Now, why for adequate evaluation you need both RGU or MCU? See, suppose a situation is there. This is the bladder, and the patient is having non-passable stricture of posterior urethra. So by MCU you can visualize the posterior urethra, but since the stricture is non-passable, you don't have idea of anterior part of urethra. Similarly, if a patient is having anterior urethral stricture which is non-passable, by RGU what you can see, you can assess this anterior part of urethra, but you don't know what is the status of posterior part of urethra and what is the length of stricture. Imagine in this patient I'm also going to perform what? RGU. So I'll be having the idea what is the length of stricture. what is the status of anterior urethra. And in this case, if I'm going for MCU, I will be having the idea what is the length of stricture and what is the status of posterior urethra. Clear? So if the question is asked for adequate evaluation of anterior urethral stricture or posterior urethral stricture or urethral stricture, so the correct answer would be what? RGU plus MCU. Now see the management of urethral stricture. Sometimes patients of urethral stricture come in emergency and they have urinary retention. If you see any patient who is having urinary retention in emergency, that person is jumping. It feels like that his soul is stuck in the bladder. And sometimes to relieve the patient, immediately we inject or we insert a needle inside and we aspirate some urine so that person becomes comfortable. So what are the treatment options for urethral stricture? Since stricture is there, we go for dilatation. Okay. If a patient is having short bulbar stricture, what is the prerequisite? Short bulbar stricture. What we can go for? Optical internal urethrotomy. Can you see? It's done like this. So it's performed at which o'clock position? Tell me. It's performed at 12 o'clock position, right? This question was also asked in exam. So we perform optical internal urethrotomy. Optical internal urethrotomy. And it's performed, these are two questions, performed at 12 o'clock position, right? And it is done for short bulbar strictures. Okay. Now see how it looks like. Suppose a patient is having urethral stricture and the length of stricture is up to 2 centimeters. See, this is the stricture and the length is up to 2 centimeters. This is the normal part of urethra. So in these patients, what we are going to do, imagine this is the stricture, length is up to 2 centimeters. What you do, you excise the stricture, and after excision of stricture, what you pull both ends together and perform the anastomosis. So excision with end-to-end anastomosis. Whenever the length of stricture is more than 2 centimeters, in this case also you have to excise the stricture, but in this case if you are pulling both ends together, what's the problem? There is tension at the site of anastomosis, and because of tension at the site of anastomosis, what's the problem? There is recurrence. So that's why in these cases we have to perform, after excision we have to perform the reconstruction of urethra. Okay, so that's known as tissue transfer. So two situations: if the length of stricture is up to 2 centimeters, so here we go for, can you see, excision with end-to-end anastomosis. So this is excision with end-to-end anastomosis. Okay. And whenever the length of stricture is more than 2 centimeters, in this case what we do, we excise the stricture and after that we go for tissue transfer. And generally this tissue is taken most commonly from buccal mucosa. Other sites are bladder mucosa and penile skin. Okay, so this is excision with tissue transfer. Clear? And the tissue is being taken from, what's the donor site? Most commonly it's the buccal mucosa. This is frequently asked question. Buccal mucosa most commonly. Other sites are bladder mucosa and penile skin. Penile skin. Now we are going to discuss Peyronie's disease. So what is Peyronie's disease? The other name of Peyronie's disease is penile fibromatosis. Okay, so the term is self-explanatory. There is penile fibromatosis. right? What is the problem here? In this case, there is chronic vasculitis involving tunica albuginea. Okay, one point. Second, you can see that there is presence of fibrous plaque, right? So you can see here there is presence of fibrous plaque located over which aspect of penis? Dorsal, and sometimes over the dorsolateral aspect. So whenever there is presence of fibrous plaque over the dorsal aspect or dorsolateral aspect, what is the problem? On erection, there is upward curvature in the penis. So can you see here, there is upward curvature in the penis? One problem. Second problem, what happens? Since there is presence of fibrous plaque here, at the time of erection, the proximal part of penis is having good erection, but what? There is poor erection distal to the fibrous plaque. Third, there is upward curvature and these patients have painful erection. Certain patients are able to penetrate the vagina, but some patients are not able to penetrate the vagina, and that leads to what? Impotence and infertility. Right? So see the important points related to Peyronie's disease. It is also known as penile fibromatosis. Clear? And in this case, there is chronic vasculitis. Chronic vasculitis involving tunica albuginea. Right? There is a triad associated with Peyronie's disease, and the name of that triad is Galezia's triad. Okay, so what are the components? This is asked frequently. Galezia's triad. So what are the components of Galezia's triad? The mnemonic is DPR. DPR. And in all these cases, there is fibromatosis or contracture, right? So D means Dupuytren's contracture. Dupuytren's contracture. P means Peyronie's disease. Peyronie's disease. And R means retroperitoneal fibrosis. Clear? Now see the clinical features. So here see, this is the erected penis in a normal person, right? And this is the penis at the time of erection in the person who is having what? Who is having Peyronie's disease. So you can see that there is upward curvature. So what are the problems? See, there is upward curvature. Of penis on erection. Second, there is poor erection distal to fibrous plaque. So poor erection. What are the other problems? There is painful erection. Painful erection. And the main problem, some patients are not able to penetrate the vagina. So it can lead to what? Impotence and infertility. So this leads to impotence and infertility. Clear? Now see, all these problems are there when the penis is erect. In the flaccid state, if you are going to palpate the penis, what you can feel? You can feel that there is presence of plaque, fibrous plaque, over which aspect? Dorsal or dorsolateral aspect. What is the good thing about Peyronie's disease? That in more than 50% cases, spontaneous resolution occurs, means condition resolves spontaneously. So what we have to give, or what kind of management is done? Observation and emotional support. So we have to tell the patient that don't worry, in more than 50% cases, it resolves spontaneously. Now see, even after conservative management, emotional support, suppose the condition is going to persist, and if the condition is going to persist, what we have to do? We have to perform the straightening operation. So penis curvature is like this, so we have to perform the straightening operation. So see, what's the problem? Here is the plaque. So opposite to the direction of curvature, we have to apply what? We have to apply the non-absorbable suture. So we apply non-absorbable suture opposite to the direction of curvature, and the name of this operation is Nesbit operation. Okay, so how we are going to manage the patient? Management. observation and emotional support. Why? Because in more than 50% cases, it resolves spontaneously. And what is the treatment of choice if condition is going to persist? This is known as Nesbit operation. We discussed that there is a technique known as Nesbit technique, which is a preferred technique for TURP. This is Nesbit operation. So this is penile straightening operation in which we apply non-absorbable sutures opposite to the direction of curvature. Okay, opposite to direction of curvature, right? So this is how we are going to manage the patients of Peyronie's disease. The next important topic is carcinoma penis, which is frequently asked in exams. Carcinoma penis. Okay, so there are basic things related to carcinoma penis. First important point, what is the most common histological type of carcinoma penis? So this is squamous cell carcinoma. We discussed that squamous cell carcinoma is more common in low socioeconomic status, and in low socioeconomic status there is increased incidence of which virus infection? HPV, and you know that human papilloma virus infection is a risk factor for carcinoma penis. Second important point, when we were discussing the phimosis, we discussed that in the patients of phimosis, the patients are not able to clean the area, and that's why there is chronic inflammation leading to increased risk of what? Carcinoma penis. So phimosis and carcinoma penis are associated. So more than 50% patients of carcinoma penis are having phimosis. It means if in a patient you are going to perform the circumcision, what happens? There is decreased incidence of carcinoma penis, means circumcision is protective, but circumcision is not protective in all patients. If it is performed within 1 month of birth, means neonatal circumcision is protective. Okay, so these are important points related to carcinoma penis. Let's discuss one by one. Most common histological type, and that is squamous cell carcinoma. So related to squamous cell carcinoma, low socio-economic status associated with HPV infection, which strains 16, 18, 31, 33. Okay, generally in which decade? It is seen in 6th decade. In Bailey it's written that 40% patients are less than 40. It means significant number of patients are young. So 40% patients are less than 40 years of age. And we discussed that phimosis is associated in how many cases? In more than 50% cases. So if phimosis is associated with carcinoma penis, what is protective? It's the neonatal circumcision. You have to remember this term. Not circumcision, it's the neonatal circumcision, which you have to remember, means performed within 1 month of birth. And this circumcision, neonatal circumcision, is not only protective in carcinoma penis, it is protective in HIV and STD also. So it is protective for HIV, STDs. What are the pre-malignant lesions in carcinoma penis? Pre-malignant lesions. So see the list. Pre-malignant lesions. Okay, one lesion which is asked in both surgery as well as in pathology, and that is known as Buschke-Lowenstein tumor. So here you can see the picture. Can you see? This is the Buschke-Lowenstein tumor. It is also known as verrucous carcinoma. What is the special feature of this Buschke-Lowenstein tumor or verrucous carcinoma? That this is locally malignant and it is having high rate of growth. So because of very high rate of growth, what happens? It is going to compress the surrounding tissue. Because of high rate of growth, so it is going to compress the surrounding tissue and it destroys surrounding tissues, not by invasion, by compression. So that's why it's locally malignant. This is frequently asked. So the name of this tumor is Buschke, Lowenstein tumor. Okay, and what is the other name of this tumor? It is also known as verrucous carcinoma. Clear? You have to remember that this is locally malignant. It destroys surrounding tissue by compression, not by invasion. Second, we discussed BXO. And what's the full form of BXO? This is balanitis xerotica obliterans. Third is cutaneous horns, genital warts, and you know, for genital warts, which our organism is responsible? HPV. So genital warts and leukoplakia. Okay, what is leukoplakia in relation to carcinoma penis? It's the whitish appearance on glans penis. What? Whitish appearance on glans penis. So all these are pre-malignant lesions. After that, two more questions are asked related to carcinoma in situ form of carcinoma penis. So see, the carcinoma in situ in relation to carcinoma penis is known as Bowen's disease. So the name of carcinoma in situ is Bowen's disease, but specifically if it is asked carcinoma in situ involving glans penis, and that's known as erythroplasia of curate. Okay, so see, carcinoma in situ forms for carcinoma penis. If it involves penis, it is known as Bowen's disease, right? So this is for what? This is for penis. Okay, but specifically if there is presence of red velvety lesion over the glans penis, how it looks like? So here you can see, can you see? This is the red velvety lesion involving the glans penis. So this red velvety lesion is erythroplasia of curate. So this is, you have to remember, erythroplasia of curate. Clear? So this is red velvety lesion over the glans penis. These are the two important points. Now coming to the most common site of carcinoma penis. Okay, so see, this is the glans penis and this is the prepuce. So what is the most common site? Here is the malignancy. So what is this? This is glans penis. So the most common site is glans, followed by this area, and this is what? Prepuce, followed by this area, and this is sulcus. So what is the most common site? It is glans, followed by prepuce, and followed by sulcus. Clear? How to remember? It's very easy to remember, and the mnemonic is GPS. Glans, followed by prepuce, followed by sulcus, right? We discussed that the malignancy is common in low socioeconomic status, age 6th decade. So generally these patients are coming to our OPD age approximately around 60, belonging to low socioeconomic status. And what is their main presentation? Patient is coming to me and saying that, sir, I'm having a problem, and he is showing the lesion. So generally he is showing the lesion at glans. So what is the most common presentation? Lesion itself. Second, it is having foul smelling discharge, and we discussed that in more than 50% cases there is phimosis, so it's very difficult to examine. So you have to hold the prepuce like this, and your assistant is putting the torchlight, and then you can see that, okay, here is the problem. One, more than half of the patients at the time of presentation, they have inguinal lymphadenopathy, right? And generally what's the problem? In penis there are crisscross connections, and because of this crisscross connections, what's the problem? There is involvement of bilateral inguinal lymph node. In how many cases? In more than half of the cases, right? Out of these patients who are having inguinal lymphadenopathy, half of the cases are having lymphadenopathy because of metastasis, and rest half are having inguinal lymphadenopathy because of sepsis or infection. It means any patient of carcinoma penis who is coming to you with lymphadenopathy, in all those patients what you are supposed to give? Antibiotics, and for longer duration of time. How much? For 4 to 6 weeks. One problem. Now see, if you are not going to treat it properly, and timely, these enlarged inguinal lymph nodes are going to erode the femoral vessels, and because of erosion of femoral vessels, what's the problem? There is bleeding and patient is going to die because of bleeding. So the most common cause of death in carcinoma penis is what? Bleeding. And the second most common cause of death is what? Sepsis. Okay, so all these are important points. Let's have a look. Clinical features. What's the most common presentation? Okay, and the most common presentation is lesion itself. It's the lesion itself, right? What are the other problems with the lesion? It is associated with foul smelling discharge. Okay, other problem, more than half of the patients, they have inguinal lymphadenopathy, inguinal lymphadenopathy or lymph node enlargement. Now what is the cause? Metastasis in 50% cases and sepsis in rest 50. Simple. So that's why any patient who is coming with inguinal lymphadenopathy, what? Antibiotics. We have to give what? Antibiotics. For how long? For 4 to 6 weeks. Simple. And what is the problem of this inguinal lymphadenopathy? These enlarged inguinal lymph nodes are going to erode the femoral vessels. So what's the problem? Most common cause of death. Most common cause of death, and that's bleeding. It's bleeding and it's caused by erosion of femoral vessels. What is the second most common cause of death? It is sepsis. So the most common cause of death is bleeding caused by erosion of femoral vessels, and second most common cause of death is sepsis. Now, what is the earliest most common symptom of metastasis in carcinoma penis? When we were discussing priapism, we discussed low flow priapism, in which the tumor emboli enters the venous circulation and going to obstruct the venous drainage. The same thing happens in carcinoma penis. Whenever there is hematogenous spread, the tumor emboli enters the vein and it is going to obstruct the vein. So patient is having priapism. So earliest most common symptom of metastasis here, earliest most common symptom of metastasis. Clear? And that's priapism. Okay. Second, we discussed another concept. What? That even in, what is the route of spread in carcinoma penis? Hematogenous spread. And what is the most common site of metastasis? Lungs. Okay, simple. But what is seen that even in advanced stages of carcinoma penis, the incidence of pulmonary metastasis is rare. Why? Because tunica albuginea and buccal fascia, these are two strong barriers and these are going to prevent the invasion of vessels, and that's why incidence is rare. Clear? So route of spread here, most common route of spread, that's hematogenous. Clear? And the most common site of metastasis, lungs. Most common site of metastasis. Clear? And that's lungs. Right? But incidence of pulmonary metastasis is rare even in advanced cases. Why? Because tunica albuginea and buccal fascia, right? These are strong barriers and prevent the invasion of vessels. Prevent invasion. So pulmonary metastasis occurs, but what? It's very late and it's rare. So now coming to the diagnosis, whatever the lesion is there, that is accessible. So investigation of choice for diagnosis is what? Biopsy. Okay. Penis is a soft tissue. So that's why investigation of choice for staging is what? MRI. So two questions related to investigations. First, investigation of choice for diagnosis. And that's what? That's biopsy. What is the investigation of choice for staging? And that's MRI. Okay. Now, there is a hot topic related to carcinoma penis which is frequently asked, especially names. What? Sentinel lymph node biopsy. So, who established the concept of sentinel lymph node biopsy in carcinoma penis? Cabana. And that's why sentinel lymph node biopsy in carcinoma penis is known as Cabana procedure. Okay. So, Cabana established the concept of sentinel lymph node biopsy. Cabana established the concept of sentinel lymph node biopsy in carcinoma penis, and that's why sentinel lymph node biopsy in carcinoma penis is known as Cabana procedure. Right? Another hot question which was asked in AIMS 2 times, that there is established role of sentinel lymph node biopsy in which malignancies? Initially, in 3 malignancies there was established role. 1, CA breast, 2nd, malignant melanoma, 3rd, carcinoma penis. But nowadays 2 more malignancies are being added. 1, head and neck malignancies, and 2nd is carcinoma vulva. So total 5 malignancies are there where there is established role of sentinel lymph node biopsy. Okay, so what are those 5 malignancies in which there is established role of sentinel lymph node biopsy? First, CA breast. 2nd, malignant melanoma. 3rd, carcinoma penis. 4th, you have to remember these 4th and 5th one, head and neck malignancies, right? Head and neck malignancies. And 5th is carcinoma vulva. Carcinoma vulva. Clear? Now coming to 8th AJCC TNM classification for carcinoma penis. Okay, so what's the 8th AJCC TNM classification? Okay, first and simplest, this is carcinoma in situ. So this is carcinoma in situ. After that, TA is non-invasive verrucous carcinoma. Other name is Bushkill-Lowenstein tumor. So that's TA. It's the non-invasive verrucous carcinoma we discussed. After that, T1 is further divided into T1A, T1B. In T1A, the tumor invades subepithelial connective tissue without lymphovascular invasion. But in T1B, tumor invades subepithelial connective tissue with lymphovascular invasion, or tumor is poorly differentiated, right? So see, what's the T1A? Tumor invades subepithelial connective tissue without lymphovascular invasion. Clear? What happens in T1B? In T1B, the tumor invades subepithelial connective tissue with lymphovascular invasion, or it's poorly differentiated. What happens in T2 and T3? In T2, the tumor invades corpus spongiosum with or without involvement of urethra, and in T3 there is involvement of corpus spongiosum with or without involvement of urethra, and in T4 if there is involvement of adjacent structures, this is included in T4. Okay, so one by one see what's T2. Here tumor invades corpus spongiosum with or without involvement of urethra. Okay, and what happens in T3? Here, the tumor invades corpus cavernosum, with or without involvement of urethra, and in T4 when the tumor invades other adjacent structures. So tumor invades other adjacent structures. Simple. So this is T staging. Now let's discuss lymph node staging. So what is N1? In N1 there is involvement of palpable, mobile, unilateral inguinal lymph node. Okay, N1 there is involvement of palpable, mobile, unilateral inguinal lymph node, right? What happens in N2? There is involvement of palpable, mobile, multiple or bilateral inguinal lymph node. Clear? So in N2 there is involvement of palpable, mobile, multiple or bilateral inguinal lymph node. In N3 there are fixed inguinal lymph node masses, or there is pelvic lymphadenopathy, and it can be unilateral or bilateral. Okay, so N3 there is presence of fixed inguinal lymph node masses or pelvic lymphadenopathy. Clear? And this can be unilateral or bilateral. Clear? Easiest is metastasis. So M0 means no distant metastasis and M1 means distant metastasis. Okay, so if it's M0 there is no distant metastasis, and if it's M1 there is distant metastasis. Clear? Now coming to the management. See, carcinoma penis in majority of cases is an accessible malignancy, and we discussed that how we are going to treat squamous cell carcinomas which are accessible. Generally we are going for wide local excision, and how much margin we are supposed to take? 2 cm. One question which was repeated many times in NEET and DNB, that for which type of carcinoma penis circumcision is sufficient. So if the malignancy is involving only prepuce, we can go for circumcision. Clear? So see the management. So here you can see this is penis, this is glans penis, and this is prepuce. Whenever the malignancy is only involving what? Prepuce, we can go for circumcision. So first option, we can go for circumcision for malignancies involving prepuce. Okay. Now see second situation. Suppose the malignancy is involving distal part of penis. Suppose it's involving glans or this area. So if it's involving distal part of penis, we go for partial penectomy. So second option, we have partial penectomy with 2 cm margin. And this partial penectomy with 2 cm margin is done for which malignancies? Involving distal part. Malignancies involving distal part. Now third situation, if the carcinoma penis is involving the proximal part of penis. Imagine the malignancy is here. If malignancy is here, we have to go for total penectomy. So what's the treatment here? Can you see? We go for total penectomy. So the third option is total penectomy. Okay. And whenever we go for total penectomy, we have to perform perineal urethostomy. So it's total penectomy with perineal urethostomy. With perineal urethostomy. And generally it's done for which malignancies? Malignancies which are involving the proximal part, which are involving the proximal part. Okay, now see this simple concept. Imagine I'm going for total penectomy. So what will happen? The penis will be something like this, because penis is removed, and urethra will open where? Here. And if urethra is opening here, what's the problem? If the patient is going to pass urine, can you see the stream? It's abnormal, and it will be very uncomfortable situation for patient to pass urine. So that's why we are going to open the urethra where? In the perineum, here, right? So that patient can pass urine comfortably in sitting position. So here patient passes urine in sitting position in perineal urethrostomy, right? Next, what are the chemotherapy agents which are used in carcinoma penis? So we use bleomycin and cisplatin. Okay, so the chemotherapy agents used, we use bleomycin and cisplatin. The next important topic is carcinoma male urethra. Okay, so how to remember? See, most common type of carcinoma penis is squamous cell carcinoma, and most common type of carcinoma male urethra is also squamous cell carcinoma. But specifically, if a question is asked that what is the most common type of carcinoma in prostatic urethra, so in prostatic urethra the most common malignancies of urethra, it is transitional cell carcinoma. Okay, so see, carcinoma male urethra, this is a favorite topic of all India people. Okay, asked many times. So first, what's the most common type? It is squamous cell carcinoma, followed by transitional cell carcinoma, followed by adenocarcinoma. Okay, so if a question is asked what is the most common type in penile urethra, most common carcinoma in penile urethra, so in penile urethra also it's same. In penile urethra is squamous cell carcinoma followed by transitional cell carcinoma. But if it's prostatic urethra, then if it's prostatic urethra, then it becomes transitional cell carcinoma followed by squamous cell carcinoma, right? So you have to read the question carefully. Okay, after that, what is the most common site? This was also asked many times. So in carcinoma male urethra, what is the most common site? Okay, so this is which junction? Bulbomembranous junction. It's the bulbomembranous junction of urethra, followed by penile urethra, followed by prostatic urethra. These are one-liner questions. Simple. Now see, what is the most common type of carcinoma male urethra? Squamous cell carcinoma. So can you tell me which organism will be responsible? Which virus? HPV. So it is related to HPV infection. Chronic irritation of urethra also increase the risk. Okay, so chronic irritation increases the risk, and in which case there is chronic irritation in urethra per se whenever patient is having stricture. So these are the risk factors. So what are the risk factors for carcinoma male urethra? Chronic irritation, stricture urethra, in stricture there is chronic irritation, and squamous cell carcinoma is there. So which infection? HPV infection. Okay, see the problem in this patient. This is the patient, this is the glans penis, and see, this is the urethra. Okay, now what's the problem? In urethra there is malignancy. So see, there is a growth or malignancy, and whenever there is a growth or malignancy and you are going to palpate the penis, yes, what happens? You are going to feel that growth. So there is palpable mass. Second, this mass is obstructing the urine flow. So what? Patient is having obstruction, symptoms of obstruction. So the clinical features, there is palpable mass with obstructive symptoms. Palpable mass with obstructive symptoms. Okay, how we are going to make the diagnosis? Investigation of choice for diagnosis is MRI with gadolinium contrast. So the investigation of choice for diagnosis, it is MRI with gadolinium contrast. So MRI with gadolinium contrast. Now see, there is malignancy, and what we have to go for, surgical excision plus minus radiotherapy. So after surgical excision we can give radiotherapy also, and whenever there is involvement of lymph nodes, generally ilioinguinal lymph node, so we have to go for ilioinguinal lymph node dissection. Clear? So the treatment is surgery plus minus radiotherapy, and if there is lymph node involvement we go for ilioinguinal lymph node dissection. Ilioinguinal lymph node dissection if there is lymph node involvement. So this is all about penis and urethra.